Good morning. I'm Gregory Thompson, and on behalf of the Columbia Business School Alumni Club of New York, I want to welcome everybody here. I think we're going to have a very informative event today regarding the Ebola epidemic. Ebola continues to ravage parts of West Africa, and while there are encouraging signs in Liberia, the epidemic continues out of control in Guinea and Sierra Leone, and continues also to threaten other parts of the continent. And even a small number of cases, as we've seen in the United States, is enough to cause severe disruption and loss of life. This summit started with a simple concern. Todd Zaman and I, from the Alumni Club, were alarmed by an epidemic for which the world seemed plainly unprepared. Our fears that the United States was not adequately prepared were confirmed when the first cases arose in Dallas. This despite all of our country's resources and know-how. We agreed that today's event should focus on those immediate, practical, and concrete strategies required to effectively contain, treat, and eliminate Ebola worldwide. We were soon joined by an excellent group of fellow organizers from around the Columbia University community, especially alumni, most with healthcare backgrounds. And they've been tremendously important in bringing this event to fruition. So this morning, you'll hear a truly stellar lineup of experts from the Mailman School of Public Health, the Columbia School of Nursing, Columbia College of Physicians and Surgeons, and the School of International and Public Affairs, as well as experts from Doctors Without Borders and from healthcare, business, and finance. Some will speak to us directly from the field, while others have just returned from the front lines. We'll have 3 panel discussions. The first will focus on medical and public health strategies. The second will focus on those countries most directly affected in Africa. And the third panel will focus on public policy, economic, and business strategies. Following each panel, we'll have a brief period for your questions. And if you're joining us for lunch following this morning's event, and we hope you will, you'll have the chance to meet with some of our panelists and other attendees and to discuss the issue further. Thank you. And right now, I'll turn over the podium to Kathleen Crowley, the first panel's moderator. Kathleen.
Good morning, and thank you. And I'd like to thank the Columbia Club, Jennifer Shaw, and her team. I'd like to thank the Columbia Alumni Association and the organizers, both Todd and Greg. Also want to thank Panel 1 organizers, Marty Romney and Helen Edelberg. And it's a privilege to moderate today with our esteemed panel here. And I'm going to introduce our first panelist, Dr. Scott Hammer, attending physician, chief for the Division of Infectious Diseases, and representing both the College of Physicians and Surgeons and Mailman School of Public Health. And my first question, Dr. Hammer, is what is Ebola? How is it transmitted? And what is the incubation period?
Thank you, Kathleen, and thanks to the organizers for inviting me to participate on this panel. I'm going to be brief with each question so we can leave time for all the panelists and for questions. So what is Ebola? Well, first, I think given the mixed nature of the audience, we have to step back and think about pathogens per se, and viruses, of course, are a major area of infectious diseases, which have been recognized more and more in the era of molecular biology. Ebola virus is a frightening term, if you will, but it's part of a group of the family of viruses of Filoviridae, which are these filamentous virus particles which cause frightening disease when they're full blown. Ebola was first diagnosed discovered in 1976. A related virus, the Marburg virus, which also causes a hemorrhagic fever syndrome, was discovered in Germany in 1967. There have been about 30 outbreaks of Ebola virus over this period of time, but the one we're seeing in 2014 is very different and much larger than any of the others. Viruses are RNA or DNA particles. They do not replicate on their own. They need to parasitize the host cell in order to replicate. And this is one of the insidious issues about viruses. They hijack and they co-evolve with humans or their natural hosts. Ebola is transmitted first. Probably the reservoir is uncertain, and others should comment on this, particularly Steve. But fruit bats are thought to be one reservoir. The virus can infect non-human primates, and bushmeat can then infect others. Once an individual is infected, the incubation period is up anywhere from 5 to 7 to up to 21 days, and the transmission from human to human typically requires intimate contact, close contact with infected secretions. I think you've all read this in the New York Times and seen it on TV, and if you've not been directly involved. And the virus can replicate in almost any cell in the body, and body fluids, that is blood, urine, semen, saliva, sweat, etc., can carry the virus. The greatest risk in a community is for those who take care of infected family members or friends, or those who go through ritual burial rites. I'll stop there.
Can you tell us how the diagnosis of Ebola can be made?
Thank you. The diagnosis is difficult at the beginning unless you're in an epidemic situation. So taking a history as a good physician or public health practitioner is really important. If somebody presents typically with fever after the incubation period, the fever is typically the first symptom, with nonspecific aches and headache and myalgias, it's a difficult differential to make. However, if you ask the history, have you been in contact with someone who died or is ill with Ebola, you can fix right in on that. And in an epidemic situation, a probable case definition is put together. So the first is your clinical acumen. Second, and the laboratory confirmed cases are those that require an RT-PCR test or an antibody test, but typically it's the PCR test. And the issue with the PCR test is that it can be negative for the first 3 days after symptom onset. So you've also probably read about that. And so the test is sensitive, but not sensitive enough such that fever, once it starts, may be associated with a negative PCR test, but 3 days into symptoms or more, it'll turn positive.
What are the clinical courses that are seen in the disease?
The courses that are seen are variable, but in about 40% of cases, and the data are still coming in, and there are 15,000 cases to date with 40% mortality, 45% mortality. The courses that are seen are, the courses that are seen are one, recovery, so that you can go through an initial phase of an influenza-like syndrome or a flu-like syndrome, non-specific. Immediately thereafter, 3 to 5 days later, you go through a gastrointestinal syndrome characterized by abdominal pain, nausea, vomiting, and diarrhea. This is the major key second phase, where extreme volumes of fluid loss can occur. Individuals can become profoundly dehydrated, need to be rehydrated, and this leads to shock and death in 40% at least of individuals. The mortality can be as high as 60 or 70% in others. So it depends on where you are and which the pathogen is and the viral titer. In about 40% or 45% of individuals, in the natural sequence of things, after the diarrheal phase, they will continue to get better and better, and they can be released after their RT-PCR is done and is negative, usually 2 or 3 times.
Could you tell us what treatments are being investigated?
So there are a number of treatments, none of which have been proven to work, but there are at least 5 different treatments out there in the experimental world. ZMapp, monoclonal antibodies against the virus, which are in production and have shown benefit in animals. Brincidofovir and a number of other antiviral drugs have been taken off the shelf, or that are being looked at for other viruses are being looked at as well. None of these have only been put out in isolated situations, and none have been proven to work thus far.
Tell us a little bit about the prospect for a preventive vaccine.
So the preventive vaccine arena is really exciting. There are 2 vaccines that have shown 100% protection in non-human primates that have been produced, one by a Canadian firm that's now been moved to an Iowa group, and one by the BRC in collaboration with GlaxoSmithKline. And these are vaccines that utilize a viral vector, to deliver the payload of an important gene and protein that hopefully induces immunity in its host. The immunity to Ebola is probably antibody and CD4 and CD8 cell mediated, but we don't really know what the immune correlate of protection is in humans. The New England Journal just published online the DRC's experience with a phase 1 trial of an Ebola vaccine, and that vaccine, by the government in cooperation with the agencies in West Africa and the government representatives, is going into a planned phase 2B trial after the first of the year.
Thank you very much, Dr. Hammer. I'd now like to introduce our next panelist, Dr. Stephen Morse, who's Professor of Epidemiology, the Global Co-Director of PREDICT, and also representing the Mailman School of Public Health. Good morning.
Thank you very much.
Dr. Morse, what do you think are the greatest misconceptions about Ebola?
I think the biggest misconception, and I thank you, Scott, for doing all the heavy lifting there. I think the biggest misconception is this talk about Ebola somehow mutating to become airborne, and spreading like the flu. And that's good material for Hollywood, but I think we've never really seen it happen in real life. We can't rule out any possibility, but I think it's less likely than my being struck by lightning right now.
How great a threat is Ebola to the United States as a potential pandemic?
Well, actually we're obviously all concerned about Ebola because it's such a terribly devastating disease, and it can have such, tremendously harmful effects. It's a terrible thing to see, and even those who survive often are, they do recover, but they're often look terrible while they're sick, as do all people. You heard about the many very serious symptoms. So we naturally fear it. Hollywood has done a lot to add to that, I think. But related to the earlier question, Ebola has its own natural history, its own environment. As Scott mentioned, it probably is a natural infection of fruit bats. People normally get it in forested areas in Central Africa or other parts of Africa where they may come in contact with fruit bats or with other animals like apes, some other non-human primates, some types of antelopes called duikers, and some other mammals that can also get Ebola, die of it, and then, of course, in a protein-poor world, you see this fresh carcass, take it home, and unfortunately share what turns out to be a dangerous meal. But in the U.S., this same type of ecology just simply doesn't exist. So all of the cases we've seen here that have not already come in with Ebola have been in healthcare workers. And that's because, very simply, they are coming in close contact with the people who are the sickest and have the highest levels of virus. And they need to observe very rigorous infection control precautions, which I think Lane Larson will be talking about in a moment. So we have had 2 people come in with Ebola that was not immediately diagnosed, was diagnosed quickly. The first one in Dallas, which I'll come back to in a moment. And he went around for several days symptomatically, and we believe that nobody can actually transmit the disease until they start showing symptoms and until there are bodily fluids that are infected that you can come in contact with. But in Dallas, this particular patient, Thomas Duncan, in fact, infected nobody he came in contact with except 2 nurses who probably were not properly prepared by the hospital in which they were working, who took care of him after. So there really isn't a potential pandemic potential. There isn't really pandemic potential for this virus. Basically, it's something that if we contain it, if we handle it, we can not really see it as a threat to the U.S., but it's a very big problem in Africa, and that's where it really needs to be controlled.
So you've talked about containment, but are there some other things we need most to control this outbreak?
People. The biggest shortage right now, although treatment facilities, which the U.S. government and other governments are building, some in Liberia and elsewhere, are necessary. The infrastructure is necessary. You need a lot of water to do many things, including decontamination and treating that dehydration you heard about. We need people who can actually deal with the patients, clinicians who can help to care for the patients and bring them over this period when they're sick, and others, epidemiologists, who can do contact tracing to find out who else might be in contact with the virus and watch them so that they can be taken care of if they should come down with the disease. Basically, we have a shortage of people, and we have a shortage of people out there in the communities to communicate this information and inform people where most of the illnesses are happening, places where they're not bringing people to the hospitals.
Are there some key lessons from this outbreak?
Yeah, I think one of the key lessons is that our fear of Ebola, I think, has been disproportionate to it's a very frightening and obviously a terrifying disease to see. Hollywood has made it worse, but it's still extremely unpleasant. There's no question about that. People are very sick when they get it. But except in a situation like what we're seeing now, the biggest Ebola outbreak in the history of this disease since 1976, nothing has changed about its transmission. Nothing has changed about the way we would control it. And I think we need to learn how to really do science-based approaches rather than be driven by fear. And unfortunately, politically, as we saw in the run-up to the last election, there was tremendous, intense interest in it, in part because it was a very good political issue for people running for office. They could show how tough they were. So a key lesson is that we need really to think about it as a disease that can be dealt with by science. Secondly, and good medicine. Secondly, it needs really recognition early. What happened in Dallas is I think really a case study of all the things that were done wrong, one of which was not to take Duncan's travel history seriously, not to take his report of symptoms seriously, and a lot of lives could have been spared. Certainly, his life could have been spared, and many efforts in contact tracing could have been spared if he had been put into isolation properly at the beginning. So people need to be informed, not perhaps feared of the virus.
Thank you very much, Dr. Morse.
Thank you.
Our next panelist, Dr. Elaine Larson, is the Associate Dean for Research at the School of Nursing. She's an expert in infection prevention, editor of the American Journal of Infection Control, and is here representing both the School of Nursing and the Mailman School of Public Health. And on your chairs today is a copy of the Institute of Medicine workshop, for which Dr. Larson was a member of the planning committee and raconteur. Dr. Larson, in regard to the recent IOM meeting, can you briefly share some insights, new recommendations in infection control?
Sure, but first let me give you a little context about what we're talking about when we're talking about isolation and personal protection equipment and barrier precautions. The CDC has published contact isolation and isolation guidelines, which we now call barrier precautions, for at least several decades. And quite honestly, most of what we do is based on clinical experience and sort of theoretical what we know about transmission of diseases. So the few studies that have been done to really look at the efficacy of contact precautions or barrier precautions have not been very clear. And it's unclear because it's hard to differentiate between whether wearing a gown, gloves, mask, etc., are actually working, or whether people just aren't doing it right and doing it thoroughly. So when I started as a nurse, one of the first places I worked was an infectious disease unit, which we don't have anymore. The TB sanitariums have closed, the infectious disease units have closed. But we had in each room an ante-room where we donned everything, put everything on, the gloves, all that stuff, went into the patient's room, then we came out, took out off the equipment, and we had a second person watching us to make sure that we didn't contaminate ourselves inadvertently. So really what we need, and the recommendations for the IOM report is, we need better studies about what exactly works in terms of personal protective equipment. We think we know because based on transmission. We need to know what are the best ways to train people. And really, we need to know what are the work systems that have to be put in place that make it easy and possible for people to follow the recommendations. So that's why hospitals are doing a lot now with working on the systems of providing care to such patients.
Thank you. In terms of protection for healthcare workers, will the usual personal protective equipment that is used for isolating infected patients in hospitals work? Or are there other precautions that are needed for Ebola?
Well, as both of the previous speakers said, a patient with Ebola loses up to 10 liters of fluid a day, sweating, vomit, and each one of those body fluids is highly infectious. So yes, we do need very good contact precautions for taking care of Ebola patients. And the problem is that many of the healthcare workers have sort of, we have to go back to the basics. They've sort of lost the expertise that it takes. And donning and doffing, putting on and off this equipment isn't easy. It's not easy to take off a pair of gloves without contaminating yourself. So it does take training. And that's why there's been a lot of training. For example, in New York, the Greater New York Hospital Association had a training session at the Javits Center, and thousands of people attended. People from CDC came, demonstrated how to take on and put off the equipment. And we really need people who are specially trained, because the more you do it, the better you get at it.
Is our healthcare workforce prepared to care for Ebola patients?
Well, as I said, I think we need, we've all the hospitals have been sort of upping the training. People are getting trained, they're having return demonstrations and so forth. It's unfortunate in some ways that the hospitals in New York have not sort of collaborated more, because each hospital is sort of doing their own thing, and that's kind of an expensive and an inefficient way to do it. So, for example, Columbia has in the Allen Pavilion a whole containment area ready, prepared, and we really need to be efficient with the way that we train people and give them the experience they need, because practice, just like a surgeon, the more she or he does a hip replacement, the better they get at it. The more a healthcare worker practices taking on and off the equipment, the better they get at it.
So you talked about how hospitals are preparing to protect the staff. Are there sufficient supplies of personal protective equipment available?
Absolutely. I mean, this country has more supplies than anywhere else in the world. The problem is distribution sometimes, and use and misuse. Sometimes we waste equipment. We waste actually a lot of equipment. If you go into the hospital, you see people wearing gloves for everything, even when they don't need to. So we have equipment. What we need is distribution systems, and quite frankly, I agree with what Dr. Moore said, and that is we need to work in Africa. This is a global community. So we are, freaked out here about 5 or 6 cases, all of which came from West Africa. when we should be thinking about what needs to be done for the global community.
Thank you very much, Dr. Larson. I'm going to take a few moments to talk a little bit about what is going on at New York Presbyterian and Columbia University. My background is I've spent greater than 3 decades devoted to workplace health and safety, both as a clinician and as a safety professional. And I'm in the privileged position to be responsible for environmental health and safety throughout all of Columbia's campuses. And taking some lessons learned from pandemic planning, we've been able to apply some of those processes to develop an Ebola plan. And if I were to say a few quick things that are really important for the university and New York Presbyterian being a tertiary care facility is plan, communicate, educate, drill, repeat. And I can't say that enough. The importance of being nimble and flexible, putting a plan down and then modifying it as the course is better understood, to take an interdisciplinary approach so that take down the stovepipes, look across all areas of operations and how we can work together. With a very complicated structure like Columbia and New York Presbyterian, we have New York Presbyterian Weill Cornell, we have New York Presbyterian Columbia, we have Columbia University Morningside, we have Columbia University Medical Center, and then we each entity have all of our affiliates. And it's important to be able to work together on a plan that protects our patients, our faculty, our staff, and at Columbia University, our students. It's taken a top-down approach, working from the provost, and Dr. Hammer is a part of that provostial committee that sets forth processes in place for the university that are in synergy with the hospital, considering we have a medical school, a nursing school, a dental school, a school of public health. And then developing an operations work group, which we have the pleasure of and privilege of having Dr. Morse be our scientific effort, along with our directors of student health services, to develop a plan to protect, again, our students, our faculty, and our staff. The use of multimedia communication, using email, websites, town hall meetings to talk about Ebola. What does it mean to the college, to the hospital, to the faculty, to the staff? And educate. We have developed huddles, online training, classroom training. We took advantage of the Greater New York Hospital Association, but training goes beyond the clinicians. We talk about our public safety officers, our security officers who are here 24/7, our custodial staff, our facilities engineer who are adjusting HVAC, and the importance of providing clear messaging about disease transmission. This is not influenza, this is bloodborne pathogen. And so that they can understand how they can do their work 24 hours a day, 7 days a week. And what we've taken is we took the Greater New York Hospital Association training, and as Dr. Larson pointed out, the importance of practicing donning and doffing. Very, very critical. Dr. Larson talked about having the buddy system when you don and doff, and just knowing how to take off that outer layer of glove or that outer gown. And so we've set up practice sessions in our student health services and in our faculty practices so that clinicians can practice how to don and doff. And then we repeat this, right? We've had this wave of the Ebola cases. Of course, New York had a faculty member, our emergency room physician, the first case in New York. And we need to recycle this and keep the information fresh. Another point is that we can't train all 20,000 New York Presbyterian Hospital and Columbia University faculty and clinical staff. It just isn't possible. So the importance of having expert teams, as we called hammer teams, it actually came from when we knocked out anthrax back post 9/11, as you had these highly specialized elite persons who are expert in Ebola and Ebola care, much like as what we've done up at the Allen Pavilion in creating a unit so that that case can be properly taken care of. So again, just a moment to take a little time out and tell you a little bit about the application of what we're talking about today. And I'd like to now resume with our fourth panelist, Dr. Wafa El-Sadr. She is both a physician and a professor of epidemiology, a researcher. She's an expert in building public health and health systems capacity, and she's representing both Mailman School of Public Health and the College of Physicians and Surgeons. Good morning, Wafa.
Good morning.
You've recently been in Sierra Leone during the Ebola outbreak. It's really hard for us here, despite the media coverage, to appreciate what it must feel like to be there. What struck you about the situation in the country, and what are ways in which the Ebola outbreak is or is not evident?
Thank you very much for the opportunity to be here with my colleagues. And I think I think nothing really prepared us for myself and Susan Strasser, who's a colleague of mine at ICAP, for arriving in Sierra Leone and facing immediately the Ebola outbreak right there on the ground. In many ways, I think Ebola dominates every aspect of life in the country. From the moment you land in the airport till you leave the country, it dominates every aspect of people's lives. What we were impressed with, were the intensive communications that have been, methods that have been established in the country around Ebola. You see billboards about the symptoms of Ebola, what to do if you suspect Ebola everywhere in the country, in the cities, in the countryside. You see banners that, again, are telling the population about Ebola. There's a whole attempt at mobilizing the whole population around this threat. I think also you can feel the efforts by the country itself to control this amazing and frightening outbreak. There are some controls on travel. There are checkpoints around the routes where they do check for symptoms of Ebola, and they take people's temperatures. All the schools in Sierra Leone have been closed since March. That means primary schools, medical schools, nursing schools. Everybody's at home. All the children are at home. There are no schools. There's no gathering of people allowed. There's a no-touch policy in the whole country. You can't touch anybody. We could not touch anybody for the week we were there. Very unsettling to live through this experience, in all honesty. On the other hand, I also saw a remarkable collaborative spirit. The international community, the local organizations, everybody working together, really trying to make a difference. And I have not seen this before elsewhere. I've been working in Africa and Asia for a lot of years. And the way people come together and the way people are trying to complement each other's work is really remarkable. And I think it offers a fantastic opportunity for the Columbia community to demonstrate that we want to be part of this. We want to be part of this response because the doors are open and the people have open arms for us. And lastly, I think also that very importantly is the economic impact and the social impact of this outbreak on the people of this country. You can imagine when there's no people coming in, businesses are staying away, business people are staying away, investments that were promised are not coming in, the port is empty. There's a huge economic impact on this country that's going to last beyond Ebola. So I think the impact is palpable. It's really palpable, but I think also the response is palpable, and I think the opportunities are really very obvious and very palpable.
Why did you go to Sierra Leone?
I think as somebody who's been trained in infectious disease and trained in public health, I feel that's everything I've been trained for in my whole life is really to be there and to try to help in that situation. It is critical that when something happens like this, that I think for those of us who bring those assets, who have this experience, we need to be there. We need to contribute to the response, and that was a very strong feeling that I had and my colleagues had, and at ICAP, is that we could not just sit far away and hope for the best. We knew we had some skills, and we had some people, and we had some commitment, and we were really eager to see what can we do. What can we do? Is there something that we can do that we can bring to the table? And that was the reason why we went to Sierra Leone.
You are a public health researcher and practitioner. What are ways in which public health can respond to the needs on the ground?
During our visit there to Sierra Leone, what we did is we had a lot of different meetings. We met with the UN response team. We met with WHO, UNICEF. We met with the Ministry of Health, with DFID, the UK military, who are responsible for the Sierra Leone response, IRC, MSF. We met with a lot of different people, had a lot of different discussions. We visited the countryside to get a sense of how the Ebola response is being done at a district level. And I think out of that, we arrived at an important conclusion, which is that public health has a lot to contribute to the response in Sierra Leone. Clearly, there's a need for people who provide care, meaning medical doctors who are there in the treatment units. They're very, very important. The medical care, the nursing care for the patients is very critical. But in reality, what's going to control this outbreak is the public health response. It is about finding cases. It is about contact tracing. It's about containing transmission. While we await, new treatments and new vaccine, but it has to be a robust public health response that will make a difference. And what do I mean by that? I mean thinking about the building blocks of the health system, the workforce. You have to train the workforce. You have to find the nurses and train them in how to protect themselves. You have to develop the systems for distribution of PPEs, protective equipment. You have to help them develop a system for transport of lab specimens. You have to find a system to do the surveillance and collect the data and look at the data and examine the data and use the data. You have to develop a system for communicating with the community, engaging the community, engaging the Ebola survivors. All of these activities that are focused on the building blocks of the health systems are at the core of what public health is all about. And I feel like we can craft a public health response by focusing on the assets that public health brings to such a situation, by focusing on those very specific gaps that we identified when we were there on the ground in Sierra Leone.
Through ICAP, the center that you direct at Mailman, you and your team have established large-scale programs that have impacted the lives of populations around the world. What are the lessons learned from the HIV response that can inform the Ebola response?
Many, many lessons. There certainly are differences between Ebola and HIV, but there are lots of similarities. And beyond just the stigma and the suffering and so on, there are lots of similarities, and particularly in terms of the response. I feel the one lesson learned is to anchor, very important, anchor all our actions in science and in evidence, rather than in fear and hype. I feel that that's the message. And I think that's what we learned from HIV, is to stick with what the evidence tells us, and really stick with what the evidence tells us, and not to waver from that because of fear or political imperative or because of other imperatives. Just anchor it in science and minimize the hype. What we found from ICAP is what we have learned is building those partnerships on the ground, the partnerships with the ministries, the partnerships with other people who are helping respond on the ground. Those partnerships are very vital. The partnerships with the community, garnering the confidence of the community and their trust in us is very, very vital. And also, yet the use of multidisciplinary teams. Our work is really based on bringing people with different expertise. The clinician, the public health professional, the nurse, the logistician, the laboratorian. It's all about multidisciplinary teams. That's all our work in HIV, and that's exactly what's needed in Sierra Leone now. So part of it is bringing those same skills and those same assets and adapting them to Ebola, and then trying to work with partners on the ground to see if we can accomplish what has been accomplished with HIV, but do it much faster, because this is an acute outbreak, and try to bring this outbreak to an end. We have to do it. The longer transmission goes on, the more difficult it will be to bring it to an end, and therefore mobilizing this response is absolutely imperative as quickly as possible.
Okay, well, that wraps us up for today. Thank you for this morning's panel. Been a great audience. Thank you.
Hi, my name is Dr. Rachel Moreski. I'm an emergency physician by training, and I am a professor both at Columbia's medical school, PNS, as well as Mailman School of Public Health. I direct the SIDHART program, Systems Improvement at District Hospitals and Regional Training of Emergency Care, mainly in sub-Saharan Africa, looking at rural emergency systems and health systems strengthening aspect to acute care. I also direct the International Emergency Medicine Fellowship Program at Columbia, where we send emergency physicians overseas to do international relief work, as well as matriculate through Mailman's MPH program. I'm honored today to introduce a very distinguished panel. Obviously, the outbreak is concentrated in sub-Saharan Africa and West Africa. And today we have a number of panelists, 2 who are here in the room with us, and then 2 who are overseas in Guinea. We're going to be Skyping with our overseas panelists, and hopefully the video will continue to work. The first panelist is Dr. Renu Dhillon, who is a senior technical advisor at the Center on Globalization and Sustainable Development at Columbia University's Earth Institute. He's been a consultant on a number of health systems programs in Liberia, Nigeria, and India, and has served on UN organizations like the WHO and UNICEF. Next to me is Jennifer Doran. She directs the Columbia University School of Nursing Office of Global Initiatives. She's directed projects to build nursing and midwifery in over 10 sub-Saharan African countries. And she serves on the Global Committee for Association of Nurses in AIDS Care and a number of other WHO collaborating centers on nursing and midwifery. Not with us yet is Dr. Estrella Lasry, who's also going to be Skyping from Guinea. She is currently a tropical medicine advisor for Doctors Without Borders, MSF, and she is working on the intervention right now in Guinea on Ebola. Next to Jennifer Doran is Dr. Susan Michael Strasser. She is the Associate Director of Nursing Programs and Project Director for the Global Nurse Capacity Building Program at ICAP at Mailman, and she oversees a HRSA-funded multi-country initiative on the nursing role of people living with HIV, and served in sub-Saharan Africa in leadership positions for many years. She also just recently returned with Dr. Wafal Sadr from Sierra Leone, so we're going to hear some of her recent findings. So I'd like to start today by having our overseas panelists give us a 5-minute introduction to what they're seeing on the ground in Guinea. And Dr. Dhillon, I don't know if you'd like to start with some comments.
Yeah, thank you, and it's a real privilege and honor to be with you all today. I've been here for now, I think, the last 6-7 weeks, and we've been very much immersed in the day-to-day of trying to get the epidemic under control, and it's always a pleasure to be able to step a bit out of that and also get a wider perspective. So it's actually not only an honor, it's also an opportunity for me to be speaking with you all today. I can speak a bit about where we are with the epidemic at a national level, what some of the challenges are and what some of the next steps are. So the epidemic here in Guinea has never been as intense or as explosive as what we've seen in Sierra Leone and Liberia. But I think what's important to understand with these 3 countries is that all of them converge along the same borders. And really the epicenter of the epidemic prior to it really becoming an explosive outbreak in the cities in Monrovia and Freetown in Liberia and Sierra Leone is really centered around this area where the 3 borders meet. And the communities in that area are all one and the same. And so it's helpful to think about this as actually something that is across all 3 countries and not just in one country. Here in Guinea, there's been 2 times where the epidemic was almost completely stamped out, last time in July. But since August, we've been seeing cases going up, and in fact, we're just getting the totals for the month of November, and we have over 500 cases for the month of November, which is the highest single month total we've had here since the beginning of the outbreak several months back. We're also seeing cases in more places than we did before, meaning some areas that were previously less affected or unaffected, we're seeing some cases there. The good news right now has been that the cases have still been on our radar, meaning we know where most of the cases are. We're able to track many of the people who are exposed to those cases, which is critical to be able to then start reducing the spread. The concern is that at any time, especially with cases here in the capital in Conakry, we can see a lot of that spread happen again very quickly and very explosively. So we have this window of opportunity right now where we see cases going up, but where we can really ramp up our efforts and even in a matter of weeks start turning things around. And that's what we're really aiming to do right now from a national level. And what we need to do to get the epidemic under control here is really a three-part strategy. One being actions that are very specific to Ebola, and those actions are very much centered around the idea of reducing the time between when somebody who has symptoms starts having those symptoms and when they're isolated. So I think with the physician in New York who was hospitalized at Bellevue, what was critical is that the moment he started having symptoms, action was taken and he was isolated for treatment right away. So reducing that symptom to isolation time is really the focus of those Ebola-specific efforts. If we can reduce that to 2 days or even ideally less than a single day, then it reduces the window of time when people can transmit the virus to others, and also it'll improve the chance of survival. Because a lot of the mortality you see is related to end organ damage, so basically kidney failure, other organs that are affected when somebody's very dehydrated. So the sooner we can get people in treatment and rehydrated, the better also. So there's Ebola-specific actions is one core area that we need to ramp up actions immediately and aggressively. At the same time, what we're trying to do is create a national response system that even in places that you're not having cases, and even in places that have been less or unaffected, where if a case showed up tomorrow, we're immediately able to act on it so that one case never becomes 10 cases, that it always remains just as one, and in worst case, maybe if they're infecting someone else in that household before they're recognized. This is going to be critical for Guinea because even as we're able to make progress on cases here, we will continue to see people come across the borders. And so we need to create a proper response system nationwide. And thirdly, we're also looking to rebuild the health system. So even before Ebola, something on the order of 60% of health facilities were effectively unstaffed and non-functional. And even as we're trying to get Ebola under control, malaria and other illnesses continue to run rampant in these communities. And so we need to build up the response for those illnesses also. And all of this stuff sounds like it's different, but it all dovetails with one another. And so what we're talking about is aggressively pushing out Ebola-specific actions that can reduce that symptom to isolation time in the context of, at the same time, building out a response system to be able to keep future cases from spreading further, and then at the same time building up a longer-term health system. And so where we are in doing that is at the national level now, we're coordinating across 40 different partners who are here, and we're basically trying to put energy behind getting priority actions in place. And one of the biggest challenges here so far has been where we still see a lot of cases happening are areas where communities have been resistant to response efforts coming in. They've also continued to be skeptical of what Ebola actually is and what it's about. And so that challenge of engaging these communities is something that is of immediate priority. So even in the next few weeks, what we're trying to get in place are essentially community-based committees whereby community members and community leaders themselves are able to act as a bridge to the population so that we can mitigate some of the concerns that are there. And I think when that happens, we'll be able to make a lot of progress very quickly. I think the story that we've seen with cases declining in Liberia is in part the fact that communities now understand how Ebola spreads and are actually able to take many of the precautions to limit contact, to not touch bodies during burials, all of these things that otherwise would end up being sources of transmission. So they've been able to make a lot of progress just by having communities understand that, and that's something that we're trying to replicate here. Secondly, we're trying to very quickly tighten up our tracing and tracking of cases. I think in the U.S. there's been a lot of discussion around contact tracing as it was done in Dallas as well as New York. And so here we've been doing that, and what we're trying to do is now tighten that up to the point where as soon as any of those contacts have symptoms, we're very quickly able to diagnose and isolate them, and at the same time that we don't lose track of contacts. Many people here are very mobile, so even if they're staying in one place, in the course of a week they may visit different family members, they may go to different places for trading, and so we're trying to create a system that can actually better keep track of people and be able to make sure that the moment any of these contacts have symptoms, we're able to react quickly. And then thirdly, what we're trying to also create is and strategy for rapidly responding to when we see cases arise in areas that currently don't have treatment centers, and places that otherwise have been less affected or unaffected. So rather than waiting till cases build up in those places, or waiting to be able to create new infrastructure, we can have almost mobile rapid response teams to move very quickly there, to do what needs to be done, perhaps using existing infrastructure, and then quickly control these mini outbreaks before they become larger foci of transmission. And I'll close my comments by giving a few thoughts about some of the bigger challenges. So the what to do is something that I think certainly we need to distill details and refine as we go, learning lessons from the field. The challenge oftentimes here is actually getting it done, and what that entails is a lot of what we're talking about sounds simple for me to describe, but it's very complex when we talk about the nuts and bolts of actually implementing it. It requires many details, coordination across many partners, and so that's been one challenge, and that's something that we're working on streamlining. Secondly, we're talking about implementing a series of interventions in communities that don't have the infrastructure you might find in even urban centers in places like Guinea and Liberia in the cities. We're talking about communities where roads are very bad, electricity, phone coverage, all of these things are problematic. And so we're trying to implement a series of very tightly linked steps in places that are very logistically and organizationally challenging. And third is information. As you can imagine just from what I'm describing very briefly, there's a lot of different pieces that are in motion at the same time. And the other thing that we're trying to do is create an information system that allows us in real time to really see how all these pieces are coming together, and almost akin to executing a war, having a sort of a full picture of where our resources are, where the challenges are, where the cases are, so that we can react quickly, redirect resources, and move faster to stay ahead of the epidemic. And I think if we can put these pieces into place, even in the next 4 to 5 weeks, I think by 6 to 8 weeks from now, we should be able to see a lot of gains in terms of reducing cases. So I'm very optimistic all of this can happen. I'm saying this at a time when we're seeing the peak of the number of cases that we've had in the epidemic in Guinea. But I think it's time that I think we're primed to really make progress in the next several weeks and get ahead of this epidemic here.
Thank you. Those were very important points, and I think we're going to come back to you and touch upon some of the points you raised. I think especially looking at resistant communities and figuring out where they are geographically and what is similar between them that creates these pockets of risk, really, and how to best mitigate them through public health programming and social mobilization is going to be key. And then other issues you bring up, and coordination is daunting. 40 actors in Guinea, there are many more in many other countries, and how you align these actors to best pool funds, resources in a symbiotic way, which doesn't always happen. We know that in Guinea that sometimes there's also challenges, and you saw this on the New York Times front page today, that creating parallel systems is not ideal, and how to integrate public health system strengthening within the fabric of the Ministry of Health is essential, but also making sure that you don't delay important response is a very delicate balance. And so we'll come back to you for some of these points. I'd like to move on to our panelists in the room. Jennifer, if you can give us 4 or 5 minute background and just some of your thoughts on,
Sure.
on the response so far in West Africa.
Sure, thank you, Rachel. And thank you to the organizers of this event and to bringing Columbia University together to be able to look at what our own responsibility as part of a global community that's demanding that we act now. I just wanted to ask people from the School of Nursing to show a hand here, because I see a lot of my faculty and students here. Thank you for being here. And I do want to note again, it was important to me when I was coming here today to recognize it being World AIDS Day, and many of our lives have been determined by being involved on the front line supporting. I know my colleague here, Susan, and many of us have spent our professional lives really working around what we thought was an unimaginable pandemic, and that we have seen enormous strides. It could go if we stop global support, but enormous strides and success stories that we really need to take and look at what can be learned from this, and I hope we have a moment to talk about it, in applying how we respond to Ebola. So a couple of comments. As a nurse and midwife, Ebola does not respect borders. Viruses don't respect borders. Our focus needs to be on the heart of where this is, which is centered right now in West African countries, 3 countries in particular, though the situation in Mali could potentially explode very quickly, and certainly Nigeria, Senegal, many places it's resting and could come out intensively. We need a global response. We do not sit, because of globalization, we do not sit alone. We cannot say, what are we going to do ourselves? We are a global community economically, socially, politically, and certainly from a health perspective. We approach it at the School of Nursing that every human being has the right to the highest achievable state of health, right? That's a right given in the Declaration of Health for All. If we really believe that, means that people who are dying now, it's our responsibility to see what we can do. From a nursing perspective, I would say we need, and I'm very glad, thank you for your remarks, Dr. Dion, because you really hit on all the points we could make. We need an immediate response. We need to be there and support in numbers, certainly as nursing cadre. Nurses represent 60 to 80% of the workforce. In the 3 countries, Guinea, Sierra Leone, and Liberia, nurses are about 10 times to 1 per doctor, and nurses are having the highest fatalities of care. Nurses are the ones in the community providing the links to education, to surveillance, to identifying the illness, to looking at ways to get immediate treatment for people, and to go through the process of grieving. When nurses die, it is frightening for communities, because if we're dying, what does it mean for anyone else, since we are usually the first line of offering hope and concrete help. So I think we need both an immediate response of how we, from Columbia University, both provide, in my perspective, nursing resources, infrastructure building, under government leadership. This cannot be our plan. It has to be a plan that will be sustained. Otherwise, we come and we do something that's not applicable. Example of building enormous medical tents in major cities. Very critical because Ebola left rural areas, but Ebola is still in rural areas. People cannot get to these centers of care right now. It needs to be dispersed, right? It needs to go to where people are, where communities are, and where the virus is. So one is immediate response. I'm also very concerned that we look at what is a long-term response. Particularly in Sierra Leone and Liberia, countries were just emerging from decades of civil strife. And how to rebuild a public health system, how to deal with maternal mortality, which is my passion in life. Countries were just starting to make steps on looking at Millennium Development Goals and moving forward. If you are birthing right now in any of the 3 countries, the chances that you will have anyone be able to provide skilled care during your birth are minimal. This is all, we're going to see a rolling back, not just to where it was before Ebola, but way back in terms of huge global burden of disease around maternal mortality and other illnesses. So we need immediate, but we also need a long-term response. And I would say strongly that this is really a moral imperative. It's a necessity that we look as a university at how we do this.
Great, thank you. I'm going to see if we have a connection with Dr. Estrella right now in Guinea, just because it's tenuous. We'll see if we can hear her. We might not see her. Are you there?
I can hear you.
Okay, wonderful. We previously introduced you when you were not online, but we were hoping for you to give us an update of what you're seeing on the ground and a little bit about the initiative that you're involved with and what's going on nationally.
Okay. So I've only been, first of all, thank you for inviting me to the panel, and it's an honor to be with the the distinguished panelists that are on, and I think a lot may come out of this panel, both in the U.S. and here on the ground. So I've only been here for a week. I came to support what we call an expo in one of the rural areas in Guinea. I've been going around. This has been the end, well, not the end, but the beginning of a trip with that started in Ivory Coast and Mali, and then I came here to support operations. So what we're seeing is as Ronald said, that there's more and more areas being affected, even if they're not, they don't have a high number of cases right now. And it's because of the increase in cases in these areas that weren't previously affected that the currently operational treatment centers are getting filled up. So there is need to spread the knowledge of Ebola and also to spread the access to healthcare and to Ebola dedicated healthcare, and also in these in more rural areas or in areas that are further away from where the epicenter of the epidemic is or was. One of the things that's important here is that there is an existing infrastructure that needs to be reinforced with both with training and supervision. And of course, this is not it's something that we needed a month ago, and we're having to speed up. And it's not something that can happen from one day to the next, unfortunately. So as much as we would like the response to be effective today, it's in some of these areas it's going to take some time. We are working, as Ronald had said, in some areas we've been working from the beginning of the epidemic in the 3 countries. But right now we're looking more at we're continuing to take care of the centers that we started with, and looking at other areas that are starting to show up with cases. One of the things that I think it's important to say is that the response to the epidemic is being addressed at very national levels, and there isn't always the amount of cross-border collaboration that we would need. In Guinea, there have been meetings with at the Malian border, and hopefully we will be seeing more of that collaboration. But of course, yeah, the epidemic doesn't know borders, and these are communities that have families on both sides and that are very used to moving either for family reasons or for commerce or for other reasons across the border. Another thing that's going to be important to set up is again to continue to make sure that the health system continues to function. We've seen when I was in Monrovia, one of the challenges was that there is very little access to healthcare out of the care for Ebola. So we need to make sure that in areas where there are few cases, that these services are maintained. We already see a decrease in patients accessing healthcare, and this means that on top of the Ebola cases and the Ebola deaths that we're counting, there's a lot more cases of malaria, pneumonia, diarrhea, both cases and deaths that we're not counting on as the collateral damage of the epidemic itself. For this, there needs to be a better system in terms of pre-triage, where the usual health facilities can easily identify the cases that could be potentially suspect of Ebola and refer them to Ebola treatment centers or to transit centers. But of course, this cannot happen without a previous sensitization. Because of the stigma associated to Ebola, sometimes we know that people are hiding the fact that they're contacts until they have a test that is positive, and this is putting a lot of people in the healthcare facilities at risk, both healthcare providers and patients themselves. So this is one of the things that needs to be ensured and set up quite quickly. Another thing is in terms of I know MSF has been very active in expressing the needs in the response, and unfortunately, sometimes the needs we saw that very clearly in Monrovia, that some of the needs come. We express them and they come they actually do come on the ground, but they come when the epidemic has, the size of the epidemic or the location of the epidemic has changed. So the response needs to be as dynamic as the epidemic is. As you know, we're kind of chasing after how the epidemic is functioning, and at some point, one of the ways to make sure that we are somewhat ahead will be to ensure that there is training and that there's sensitization and that the information is getting to all of the healthcare providers, including traditional healers and less I'm going to call it less conventional healthcare providers, and some that sometimes will escape the system and the usual system of training. Yeah, and I think since it's World AIDS Day, one of the things that I maybe will end with this is also to make the parallelism between HIV and Ebola, which I think it's quite interesting, and it might help shape our response. So in terms of the disease itself, even the way sometimes the patients look is very similar to patients in advanced stage of AIDS. And the stigma associated is also very to Ebola is also very similar to the stigma associated to HIV, with people not wanting to get close to anyone that's associated with the disease, whether they be patients, survivors, or healthcare providers associated with the disease. And that's something that we're only going to be able to fight with information and sensitization. So.
Wonderful. I mean, not wonderful, but thank you. I mean, those were very insightful and obviously current impressions, so thank you for that. We're going to come back to some of those points. We're just going to finish with our introductory remarks. So, Susan.
Great. Thanks. I'll just be brief because I think our panelists have already said a lot of the opening remarks. In general, I would just like to say my impressions. I came back from Sierra Leone almost 4 weeks ago now, and I'll be returning on Thursday to Freetown. And I've spent most of my adult life living in Southern Africa, in South Africa. I just returned from 8 years in Zimbabwe, in Zambia, and before that lived in Zimbabwe. And I often think as I move back and forth between the United States and Africa, what is different? And because I see the same passion, I see the same intellect, I see the same drive for excellence. I see many similarities between the people in Africa and here, but something is palpably different in how we can live our lives. And what strikes me again and again and again over the last 25 years of going back and forth and living there is the infrastructure, just the sheer depth of infrastructure that is within the United States that we, growing up here, largely take for granted. And that depth of infrastructure, in addition to the resources, is really what makes a difference. And when I went to Sierra Leone this time with Dr. El-Sadr, we got to the hotel where most of the government, UN, international NGO field workers were staying. And I was struck by how many people were sitting down at their computer, writing up standard operating procedures, writing training curricula, writing materials. And as a nurse, and the nurses in the audience, we're doers. We want to get up and we want to make something happen. We want to fix the wound. We want to care for the patient. We want to give an injection. We want to do something. And sitting there and writing was so counterintuitive to my nature. It just really hit me on a very visceral level. And what it made me reflect on is that we're sitting there building the bridge while the water is rising. So we're all saying, what can we do? What can we do? What can we do? What we need to do is for the long term. We need to help people develop health systems that keep their people healthy and help them respond in times of crisis. Because we all know it's much more expensive and highly inefficient to do it while the water's rising. And that's what we're doing now in very chaotic and very expensive and difficult ways. So I think for me, that's a big take-home message I would like everyone to think about is we need to be in this for the long term. We need to help and work alongside of our fellow man in places of need to help build health systems. It's not surprising that the countries where Ebola has hit hard are countries that have had a legacy of conflict, of very decimated infrastructure. In the United States, there's about 100 nurses for every 10,000 patients. Before the Ebola epidemic, there were less than 2 per 10,000 patients in Sierra Leone. And the numbers of those very few healthcare workers, 6,000 of them, that have died is extreme. So the infrastructure we began with was very weak, very disjointed, and then to layer on top of it an epidemic that we've never seen before in the world is we are really learning by doing, and we are building the bridge as the water's rising. And I think I'll leave it there as we move forward for questions, and I can explain a little bit more about what we will be doing when we go back on Thursday.
Great. Dr. Lansry and Dr. Dillon, are you still there?
Yes.
One of the points that you brought up in terms of the sort of gaps that you're seeing in terms of infrastructure, consumables, medication, human resource, can you talk a little bit about, I know that you're working in a particular place that's rural, but what are those gaps, and do they differ from the urban centers where the ETUs are at versus the rural centers? Dr. Dillon alluded to this earlier in the more rural areas, and we know that obviously the infrastructure that Susan just alluded to comes into play in terms of access to roads, access to triage, access to communication. But how do you sort of see the landscape of those gaps from your vantage points?
The needs are there on, so the way I think about a lot of resource needs and supply needs, there's about absolute supply, and then there's about distribution, and then related to distribution is also the ability to keep track of it, being supply management, so that you're not stocking out. The needs are sort of there on all three levels. So at an absolute national level, we're still closing gaps. Right now we have, for example, for the protective equipment, we have stores of that can last through the end of December, but then we're going to very quickly need to re-up our supply in the next few weeks so that we have going forward. So the absolute need is there. The distributive need is also there, and in fact, we're trying to quantify exactly what that looks like. You'd understand that in this country, even when the distances are not that long, taking something by road can be a matter of like 16 hours, to the equivalent of what we would drive for like an hour in the U.S., for example. So we're having to actually airlift a lot of supplies to different places. So that distributive issue is still there. And then thirdly, Estrella made a great point about how are we going to get non-Ebola specific healthcare units, meaning your regular health centers, your regular health clinics. They need to be attuned, ready, and equipped so that if they were to see cases or potential cases, they're able to act in a way that's safe and effective. And so when we're talking about supply chains, we need to get supplies all the way down to that level. And so all three are a challenge that we're actively working on closing. That second and third one are particularly difficult because what we're really dealing with are really complex logistics, because we're trying to move so many different supplies, keep track of them, but then also doing it across wide areas where infrastructure, roads, the ability to move things from one place to another is very challenging.
Great. Dr. Lansry?
Yeah, I can add to that. I did I guess 300 or 350 mile trip the past 2 days, and it took me 2 days to do that because of the state of the roads and And yeah, because it's difficult to drive here by night and to be safe. So yeah, that's one of the things that is difficult. In terms of one of the things is there is a supply chain that has been put in place for Ebola dedicated structures, but the supplies are not always reaching the health centers, community health workers, and not all non-Ebola healthcare. And those are the people that are in the front line that will be the first to identify the cases. So even it's difficult to, so they don't only need to have gloves and masks and goggles and potentially personal protective equipment, but they need to know how to use it. They need to know how to undress from it without getting infected. We know that a lot of the infections come during the undressing process, and they also need to have a safe waste disposal so that gloves that have potentially touched an infected patient won't be laying around in an area where kids are playing, and then potentially cause a spread of the epidemic in that way. Knowing that the virus lives for a very short time in outside of body fluids, but we still don't want all of those materials in laying around in the ground. So the waste management of all of that, of all of the protective equipment, is also going to be a challenge, and we've seen it. I've started to see it here. We saw the same thing in Liberia. In terms of it, it's easy to put in place protective strategies, but it's not always the waste management and all of the logistics that need to accompany that are not always easy to put in place.
Very good point, and that's true for many different outbreaks, whether it's cholera or Ebola. We see waste management as a huge challenge. You both touched upon, I think, an issue, and I know, Susan, you also went to look at this issue, is that we know there's been a lot of focus on developing these ETUs, right? These hospitals that really focus on Ebola treatment units where they're pretty well staffed with both local and as well as international staff to deal with just Ebola. We know that health systems have shut down. Access to maternal care, immunizations for children have shut down. Access to care for just general disease has really sort of been halted. A lot of initiatives have taken off to, one, try to decentralize care away from the ETUs to build both community care centers, as well as home units. We know UNICEF and Save the Children have had huge initiatives on trying to decentralize that care. I was wondering from any of you, and I'll be more specific since you can't see each other through Skype, what you're hearing or your direct experience is on the efficacy of these initiatives. And we know they're different in different locations. As Estrella sort of alluded to, it rapidly changes. So you'll have a need one moment, and then you have to be very adaptive. But we know that, at least from the CDC's MMWR report, they did a modeling of this, that you can have the most sort of risk reduction in transmission at the ETUs, followed by the CCCs, followed by very well sort of thought out home care, to have sort of safe home care. And obviously the home care and the CCCs are not the ideal, but when you can't get an ETU in every corner of every rural village, these are sort of plan Bs. And so I'll open this up first to Susan to comment, and then I'd love to hear your thoughts from the field.
Yeah, I don't know if I would call it plan B. I would say you need all of it. You need isolation in the home, you need referral to something that's nearby, and then if you can, to refer them on to an ETU. So I think we need all of it. And in this discussion, I think it is very rapidly evolving, because when we landed in Sierra Leone, again, the whole idea was to build this bridge and build a very good steel suspension bridge with all the bells and whistles. So all of the talk was about get these ETUs up, get these Ebola treatment units up, get bricks and mortar buildings up. And people realized, well, the water's coming up too quickly. We can't do that. How do we respond? And that's why we're seeing new models of care, the community care centers and home care. And these were not even considered an option, a couple months ago, and would have been unheard of, unthinkable that you could care for an Ebola patient in the home. And now it is seen as something we have to do to get ahead of the epidemic. So we'll be going back to evaluate community care centers to look at how safe they are, how effective they are. But basically what it is a community model of care, and there's a rapid scale-up of many of them, hundreds of them, happening very, very quickly. And there are a series of tents to isolate suspected and confirmed cases of Ebola, and they should be places in communities where families can quickly bring their loved ones who are showing symptoms of Ebola. So that would be fever and a number of symptoms, or symptoms and having exposure to someone who's been sick. At the same time, we know that people are caring for their family members in the home before they bring them into the hospital. So how can that be done effectively and safely? So home care kits and minimal home care kits are being thought of and distributed as well. And we will be looking at the effectiveness at the community care centers and the acceptability to the community to get people in to a safe place where they can be isolated but also cared for. And as Dr. Dillon said, they need oral rehydration quickly to prevent damage to the liver and to the kidneys. And so that is a key component of care in the community care centers. And these are going up very, very quickly as we speak. I was on the phone yesterday with people from UNICEF in Sierra Leone, and they're being built and put up very quickly. The issue is getting the people to man them and getting the people trained quickly enough to man them. Because as you know, there are very few nurses and doctors to be put into these facilities, and many of them are being drawn into the Ebola treatment units.
Thank you. Dr. Lensry, do you want to go first?
Yeah, one of the problems with of course there need to be this epidemic has made us thought of the way to provide care in a different way that we have in other epidemics, and we've had to adapt our forms of treatment. We had done home-based care in previous interventions when patients did not want to come to a center, but of course with a much smaller number of cases in a much more controllable and supervised way, where the patients who were being taken care for at home would be visited by a healthcare provider, by whether it be a nurse or a community volunteer, or sometimes a doctor, once a day or once every 2 days. So this can be done. The problem is now if you offering this as a possibility with a support, with a supervision support, would require an incredible manpower, which is not available right now. A little bit similar for the community care centers, where it's important that there are trained staff to man these community care centers, so that they don't become very quickly centers for amplification of the disease. We know that without the appropriate training, the health facilities very quickly is one of the areas where very quickly people get infected, and where a healthcare provider can in turn infect other patients. So in terms of access, it is a great idea, but still you need enough people to manage it. So essentially what they end up becoming, or in terms of needs, is a small scale ETU, which again, right now the human resources are not necessarily available for that. One of the things that we're trying to propose is just to ensure that all healthcare facilities do have an area for isolation, where they can quickly isolate a patient that they identify as a potential suspect, and at the same time alert the rapid response teams that Ranu was talking about before, so that this patient can quickly be picked up by an ambulance with trained staff and taken to an ETU. But again, it's all training, and finding the HR that will be willing to work on this, and at the same time making sure that it's the same human resources that are taking care of the rest of the healthcare. So, not undressing the rest of the healthcare to dress up the Ebola response.
Thank you. It's nice to get different perspectives on this issue, because we know that this is the first time, really, that we're trying to figure out how to improve access closer to the community. And we have huge human resource shortages, and training is essential in every aspect of this process, as we all know. Dr. Dillon, do you want to also comment?
Yeah, I think this question of community care centers versus the traditional larger treatment units has been going on for some weeks, and I think before jumping to what infrastructure or what unit of response we're trying to create, to me I think it's helpful to think about the functionality that we're trying to create. And to me it's this, to really to stop spread of Ebola, to stop transmission and improve survival. To me, it comes back to really reducing the window between when someone first starts having symptoms and therefore can pass the infection to somebody else, and then they get isolated. And so the ideal thing would be someone's in their home, they start having a symptom, they can immediately call somewhere, they could be transported somewhere where they can be diagnosed as positive or negative. Particularly since a lot of the early Ebola symptoms are non-specific, meaning that they're the same ones as you may have for your regular viral infection or for malaria. But then you can go very quickly, be diagnosed, and then if you are positive, you can be taken to a place where you can be isolated and treated. So to me, that chain of symptom, transport, testing, and then isolation and treatment is really what you want to create. And then the question becomes, what is the most effective way to do that in different settings? So in Sierra Leone and Liberia, where there's some differences between the way the epidemic has evolved, even though it's the same epidemic and across all borders. It's evolved in different ways in each country. So in Sierra Leone and Liberia, you have a situation where not only do you not know who the contacts are, meaning the people who have been exposed to somebody who had Ebola, we don't even know who 40 to 70%, depending on the statistics you look at, of the cases are. So when there's so many cases that are happening in the community that we're unaware of, you almost have to assume that anyone can be a contact. Yeah. Anyone could be someone who's exposed. So when that person comes to you with a fever, it's even more imperative that you test them, because they very well could have been at home with somebody who had Ebola. In Guinea, we're still in a situation where we know who many of the cases are, although that's become increasingly difficult, especially in some communities that have been very resistant to response efforts coming in. But we know who many of the cases are. We feel like we have a grasp on who many of the contacts are, and we're following many of the contacts. So a lot of the cases that we find here are people who have a fever at the home or a symptom at home. The person who's following them at home realizes it, calls it in, and then they're able to be diagnosed. So that in that instance, you can do something where you don't need as much, in some sense, decentralized in terms of a treatment unit as you may in Sierra Leone and Liberia, where you have many more cases at the local level, and an inability to really differentiate cases as easily. The second thing is, I think, from looking at this from the Guinea perspective, to me, what you want to do is you want to create a place where somebody who may have Ebola can be at home. They can be immediately isolated. So that means having families have basic protective equipment and also being aware of what to do if somebody has suspicious symptoms. You're able to safely transport them to what could be, what we call here almost like a transit center, which could be a community care center, depending on how you look at the terminology. They can get there. At that place, they can get a sample taken to be tested at the labs. If they're positive, then they can be moved to some place that's specialized in Ebola treatment, so that these centers don't become mini Ebola treatment units, as Estrella is pointing out, but actually end up serving as diagnosis and transit points, almost to just be able to keep people safe and isolated until it's clear whether they need to be taken to a treatment unit, where they can get the full court press and have people who are trained in all the right protocols treating them, and at the same time they can get the oral rehydration started immediately at this relay point. When we get rapid diagnostic tests, which have sort of been cooking for some time, and I think we're all eager to see when they're going to be available. That can change this dynamic significantly, because with the rapid diagnostic tests, especially some of them which are simple to apply, you could conceivably even do diagnosis safely at a household level, which right now you can't. And in that instance, it might be easier to then quickly identify if somebody is Ebola positive and maybe ship them directly to a treatment unit right away. Or if you're in an area where you have more than just a handful of cases, you could create something of a mini ETU in that area so that it's easier to manage the cases there. So I think just to summarize what I'm trying to say is that I think we look at the functionality, then we can use these different tactics to basically create that functionality as effectively as possible, understanding that it's going to change as the epidemic moves and as our own capacities change. But I think that would be the way to think about this, rather than it becoming a sort of a choice of different approach, a binary choice of one way or another.
Yeah, it's definitely rapidly changing and evolving as we go, and we really are learning by doing. I think the latest reports for this week from Sierra Leone show that there were 36 patients accepted into community care centers, 36 or 38, and 26 of those had been referred on to Ebola treatment units. So it needs to be part of a continuum of care, and exactly as Dr. Dillon said, it's not an either or, it's all of the above. And each stage along the way is a critical point to provide care, provide a way to stop the transmission from one person to another.
Absolutely. And we know, I mean, countries that I work, there are often 80% of deaths happen in district or sub-district level for non-Ebola cases. We see this with diarrhea, pneumonia, malaria, maternal mortality. And so if this continuum doesn't happen from the household through the community up in an effective way for every disease.
I come at this situation from, like many of the previous panelists on the other panels, from a very public health, public policy point of view. However, I want to make just a couple of points about that, but I also want to spend a minute or so talking about the potential for the public-private partnerships, the investments. What is this about? What are the possibilities? I'm going to try to keep this to about 5 minutes just to give some introductory flavor, and then the other panels will join in, and hopefully you all participate as well. So first of all, we look at this I run the National Center for Disaster Preparedness. So from our point of view, this is another in a long series of massive public health catastrophic events that we characterize as large-scale disasters. But the category of large-scale disasters includes everything from the terrorism we saw on 9/11 to Katrina and Sandy and the accident in Fukushima and the tsunami associated with it, et cetera. But in the context of a biological threat from nature or from other sources, including terrorism, I think we have understood these very large-scale events to be above and beyond, as a first sort of characteristic of what we mean by this, and we call them mega disasters, is a situation that overwhelms the potential of local resources to solve the problem, to deal with the response, to save lives, to, in the case of other kinds of disasters, to recover from the disaster, and so on. And I think this Ebola outbreak fits, obviously, virtually all of the key characteristics that we're going to see here, including, when this eventually ends, the so-called recovery from the Ebola crisis in West Africa is going to take a very, very long time, because we're dealing with countries that are immersed in serious socioeconomic deprivations and poverty, and really a serious lack of a healthcare infrastructure that's up to the task of, in many cases, of dealing with day-to-day public health needs. And then when a crisis happens, and as was said in the previous panel, people are dying and lost, it just further weakens the healthcare structure. So the recovery here is going to be also a very long-term need, much like Haiti post the earthquake there a few years ago. And I mention this now because if we don't start thinking about recovery and what that means at the beginning of the process, that means that we'll leave there and the cameras will go away and the coverage will stop, and we'll still be in the same situation of high vulnerability that we're in before. Second point related to that is that this is clearly a global problem with global consequences and therefore global responsibilities or international responsibilities to deal with this. And as there have been multiple outbreaks of Ebola, usually easily contained, and other diseases like Ebola, by the way, it has not reached an international stage like Ebola is. Because the occurrence is so extraordinarily high in West Africa, and because we've had these creeping episodes of Ebola that have appeared in Spain and in the US and so forth. So it already has the notion of people understand that this is a much bigger Ebola crisis than we've had before, and it is also affecting beyond West Africa. The second point about this is that the key to solving this problem, like virtually every other biological type of threat that we might face, is to be as upstream as possible. So the focus on the downstream consequences of how do we care for individual people that arrive in a U.S. hospital, let's say, or even treating people who are affected by Ebola in the countries that are principally affected in West Africa, is not enough. We have to get higher up in the realities of why we have these issues and what are we going to do to prevent them in the long term. In other words, treating the downstream consequences is going to be ultimately and virtually always is insufficient to bring a rapid and efficient end to a threat such as this. And key to that point of getting upstream is really science and the investments that are needed in several different areas that I think are absolutely critical for Ebola and many other illnesses or conditions like that. And those scientific advances that we desperately need right now are in several areas, one of them being in early detection. We have to get much better at virtually instantaneous recognition of what we're dealing with in a very specific way. I mean, it's, in 2014, for us not to be able to do a one droplet blood test and know that we have Ebola like right now, I'm a little disappointed in my humankind here. I think we can and should be doing better. Now, this is very, very difficult because of the structure of the Ebola virus, because of early detection technologies, because of low viral loads in the beginning. I'm not saying it's not hard, it's just something that we need to be investing in for this and other diseases. The second area where we need science is on the prevention side, and I'm talking about here either dealing with the underlying conditions that produce a recurrent virus like Ebola that is so deadly and often self-contained, but this time not, is to make sure that we have the vaccines that are necessary, that are developed and produced at a rate that's able to make sure that people are safe. And that is really a critical issue here. It's going to take a long time to build a true, robust health and public health system in places like Liberia and Guinea and so forth, and Sierra Leone. But in the meantime, we really need this vaccine, and we need it fast. And not only that, we need techniques that will allow us to develop vaccines very rapidly. It's not just developing them, but producing them in sufficient quantities and having a system to distribute them and administer them. All of that has to be part of the essential work of the science-based strategies here. And the third piece has to do with the countermeasure development, the antibacterials, the antimicrobials that are needed to treat people very definitively. We're dealing with a very, very primitive health and public health response. We're treating people more or less like we did 100 years ago. I guess we have better PPE right now, but basically we're using the most profoundly old-fashioned tools to deal with this current day threat, and it's just we kind of need to get beyond that, and we need to be able to have the investments made in those three areas: detection, prevention, and countermeasures, to really make progress. And that progress that we make on Ebola should never be thought, in my mind, to be only for Ebola. We have to be thinking and investing in ways that make sure that we have these capacities built into the system for now and for the long term. So the final point, I just want to make a point or two about issues having to do with the private sector and investments in this and what's in it for people with capital or people with vested corporate interest in developing, let's say, a vaccine, how does this end up being a win-win-win for everybody? And right now, it's a little hard to see how that gets manifest with respect to the Ebola crisis. I'm going to say this with, admittedly, a very kind of elementary school level knowledge of what social impact bonds are supposed to do and how they work and all that. I just don't see how this, and hopefully our other panels will shed light on this, but my understanding is that if you're going to make an investment, let's say in something that would save Medicaid in the US X amount of dollars over a decade, then an investor says, okay, we're going to fund the interventions that will improve the quality and the outcomes from whatever we're doing, well, let's say with the Medicaid population, but in return, we want to see our investment rewarded with some even low-level interest, so that we've said we've made a difference socially, and we're returning to from our investments, we're returning some level of gain on that money invested. There you have a payor with a specific interest in keeping the costs down. That would be Medicaid or Medicare, let's say. I'm not sure who the payor is in the case of Ebola. Like who's going to say we've saved money because you invested $100 million? How do you measure that? Who actually produces the return on that investment? And I'm not, again, this is total naivete, and I'd be interested to hear what other people have to say about that. But I don't know how that works in a situation like Ebola. We just need money here. We need money to stimulate maybe the development of vaccines. Obviously, we do. We have government agencies that are BARDA and its BioShield program, for example, that are dedicated to try to find ways to make the investments to accelerate the process of developing detection, vaccines, and countermeasures. But other than the direct charitable contributions, which I think we should be seeing a whole lot more of, we've had very little of the money committed. The 1.4 billion is actually materializing. Very little money coming from just individuals. And I don't think the international community is as yet responding as charitably as we did even with, let's say, at Haiti, which was a much, much more robust investment in helping people. So hopefully the panel will help explore some of the ways that these other kinds of strategies, social investment, social impact, et cetera, will manifest themselves. So I'm looking forward to hearing as much as I can about that. So.
Thank you, Dr. Adlana. I'm Wendy Diller, by the way, and I'm not Les Letter, who is delayed. So, and I helped organize the panel. I know you have to leave. I do have a question for
Sure.
you, and that is there are some government initiatives to help encourage private industry to undertake some of the development of testing and
Right.
vaccines. Are there any particular initiatives that you think that the government should be doing, or that that will work well or could work well?
Well, let's take the issue of vaccine development generally. So the government, through BARDA and through BioShield, I guess, is to my understanding, it says, we understand that you're a pharma company, this is what you do for a living, but it costs let's say $1 billion to develop a new drug or vaccine. I'm not sure if that's entirely accurate, but it's somewhere in that vicinity, at least that's so claimed by the pharma industry. And they say, well, I don't really want to do that because I have for a disease that's actually quite rare and will not be won't be an ongoing market for it. So they'd rather work on some other kind, a measles vaccine or something else that's much more prevalent, where they could see a profit at the end of the tunnel here. But for these more unusual outbreaks like this, the financial incentive for a company to invest in the R&D necessary to produce that vaccine in particular, for example, is not really all that clear. So the government's idea is that we'll help support the R&D. You develop this, so or we'll guarantee the purchase of it. But something along these lines has to be understood in order for the big pharma to divert from its big-time profit-making needs and its ability and willingness to develop vaccines, let's say, for more unusual situations.
Right. Okay, thank you. Do the panelists have any questions for Dr. Redlener?
Or
Why don't we
strong
do?
retorts would be okay also.
Yeah. Why don't we do this while we're waiting for Les? Also, we have 3 other distinguished panelists. Why don't we go through them one by one? I'd ask you to introduce yourself briefly, since Les is not here at the moment, and your areas of expertise actually dovetail into many of the comments that Dr. Redlener had made. Perhaps you can expound upon that in relation to your experience with your work. So let's go with Christopher Ream. If you could introduce yourself quickly, please.
Sure, and thank you for having me today, and thank you for your comments. I may have a few retorts or thoughts on how social impact bonds, or more accurately today, pay for success, may be relevant here. My background is not specifically in healthcare, however, it is in understanding how we engage the private sector to invest largely into areas of public interest, public outcomes. So I am a managing director at the Community Development Venture Capital Alliance, which is an association of many different, mostly for-profit venture funds, but all of which hold some type of social mission in mind. Many of those are mostly community investment minded, jobs related, but the questions we deal with in these funds, as well as the fund of funds that we manage, relate to questions of understanding how do we engage the private sector into areas where it's not obvious who is a payor, that there's an obvious market solution for problems. Healthcare is such a natural one, it's amazing to me that there isn't more already established. I'll keep my comments really brief, but almost to follow just from what you said, in an environment where there is not necessarily an obvious payor, in the case of who's taking care of Ebola, it's hard to understand how investment is going to be attracted to, just as you said, finding innovation in vaccines. But we should think about investment at 2 grades. And these are almost time-delimited grades. One is infrastructure. We heard in the last panel just how little infrastructure there really is in some of these countries that would provide the baseline support for any kind of disaster or disease response. So we can talk about investment's role over that position, separate from more of what our funds are doing, which is investment in innovation. How are we, in fact, moving ahead on research and development on those areas that aren't immediately obvious to the private sector, where we already have a large public sector response to research and development, which is brilliant and can always be expanded, but the commercialization of that is always the question. And so I would just suggest that let's talk about social impact bonds, or pay for success, as one model. Another would be a wholly private model in which there are teams of people ready to go and there is a public sector payor when needed. If that were immediately obvious, it probably would be done already. But in the idea of pay for success, there are really 3 participants that need to come to play. There's a public outcome that has to be addressed, for which there's some public sector participant already playing. There is a private or social sector intervention provider. And then typically there's also some type of risk provider involved. So the social impact bonds, the 26 or so that have been done to date, have all been involved in a way that some foundation is largely covering much of the risk that private sector source of capital is responsible for putting to place, in the belief that the intervention provided will then be a cost saving such that the public sector will pay for it with some profit. Okay. All the questions about whether or not that model is appropriate or works, we can hold to the side. But in terms of healthcare, there are a lot of reasons to believe that it can be done and it probably should be considered. In fact, we should have these vehicles in place and understood so that we can respond more quickly in these types of emergencies. But we already see a lot of foundation money moving right now on this particular disease. Just one example is Gates. While that money is incredible for its use right now, it could also be a very, very valuable leverage to attracting private capital. The idea of being a risk loss or being some type of risk leverage for other private capital to follow should be what we talk about in terms of pay for success. Though the payer may not be obvious, in the end, it's those foundations that keep coming up with money when no one else does. World Health Organization has to go out and find money when no one else does. There are payers. It's just very reactive, not proactive. And perhaps if we were smart, just like investing in infrastructure, we invest in the ability to be more responsive. Let me stop there so I don't get too far afield, but
Great,
follow.
great. And Jeff, I'm going to let you say your last name since I don't want to
Sure,
mess it up.
absolutely. My name is Jeff Slugmelch. It's spelled just how it sounds. And
You've been asked this.
yes, yes. I'm the managing director for strategy and operations at the National Center for Disaster Preparedness with Dr. Redlener. My background is in public health. I have my MPH in health policy and management, and also my MBA in business administration. I think that a lot of really interesting points brought up here that really center around this concept of public-private partnerships. And I was doing some research a little while ago into public-private partnerships, and it was interesting that I found the best articulation of what that is actually from outside of where you might expect in the emergency management community, not that they aren't doing a great job. I found an article in the International Journal of Supply Chain and Logistics Management. Thank God for search engines, right? Yeah. And also in public administration, really looking at kind of what is the business of response. And from these, I think some really important insights were that, government is often seen as the lead actor in disaster response, as it, should be for a lot of reasons. But that the actual operation of response is a conglomerate of public resources, private resources, nonprofit entities. And bringing these together in these partnerships, we have memorandums of understanding that might set the terms of a relationship, but the effectiveness of the relationship is really through more informal relationships and through trust being generated through planning together and practicing together and preparing together. And also that, where there's a lot of emphasis on federal funding, and I think, it does a good job of creating a baseline level of preparedness, but it also can only go so far when you have an inherently political appropriations process. There are going to be blind spots to the interests of the private sector, and areas where the private sector is just better leveraged to be efficient. So I'll talk through just a couple of examples of the current Ebola response that the private sector has been engaged with that I think are very interesting, and maybe they'll provide some context for discussion. The first is we were talking about the pharmaceutical supplies. So a lot of the things you've heard about, ZMapp, these other drugs, were actually developed under grants from the government to do small-scale testing and development to kind of move things up in the pipeline at a way that was at low financial risk to the research and development of it. There's also been a lot of work done over the last 10 years to create emergency use authorization mechanisms to essentially reduce the approval timeline of getting drugs to market. And although we haven't seen them in mass quantities being developed now, they are under development, and we're looking at a turnaround of less than a year on some of these, which is really unheard of 10 years ago for that. And I think a large part of that is the relationship between the public and private sector in creating strategic investment, creating subsidizing research and development for drugs that may never be needed, and allowing companies to look at their chemical profiles and creating these databases to identify what might be effective so they can rapidly turn that into a commercially viable product that also meets the regulatory requirements. So part of it is investment, part of it is just making it easier to do business and being more sensitive to the risk calculations of the private sector. Another kind of more micro example, folks may have read about the Firestone plantation in Liberia. So here's an example of where actually the rubber plantation was really decimated from the civil war that had occurred there and is slowly being brought back. And so the threat of Ebola was very, very felt in terms of the potential long-term, short-term and long-term impact on the financial viability of that plantation. And so they had a health clinic, and basically while the Senate in Liberia was arguing over whether or not Ebola was real or a ploy to get more foreign aid, they were ramping up with a war room. They converted pickup trucks into ambulances. They took their land surveyors and turned them into epidemiologists. And so they were actually able to prevent an outbreak among their staff and their families, even though in surrounding villages were being incredibly hard hit. That number was 80,000 people who were essentially removed from having to be under the care of the government and essentially removed from the denominator. And then as they were able to stabilize, have started opening up services to people from outside those immediate responders. Now with that comes a lot of controversy as well too, such as where does a private sector company sort of draw its borders on where its concern begins and ends. So you have a lot of arbitrary political borders, arbitrary corporate borders, and then diseases that know no borders. But still, I think it's a very interesting kind of force multiplier for what is trying to be achieved in the public's interest is also congruent. And finally, just in the last couple of months, there's been some insurance policies being offered to organizations for non-physical damage disruption to revenue. And it's designed for healthcare organizations, among others, that have, if staff get quarantined or if a facility gets quarantined and essentially put out of business, it creates a private sector mechanism for covering the loss of revenue associated with that. This concept is potentially a game changer for the way we respond to infectious disease. Along the same lines of the National Flood Insurance Program and earthquake insurance in California, it takes a lot of the uncertainty out of conducting business during times of a pandemic. It also alleviates the burden of the business either having to either go out of business or reduce staff or rely on government support. So again, there's a lot of activities that can be done in tandem with the public sector, but then there's also a lot of work that the private sector does every day that if we create mechanisms just to allow them to continue to do that, takes some of the pressure off of the public sector for doing that and allows those resources to be focused on areas that maybe don't have a commercially viable application. So I'll just conclude by saying that I think a lot of times one of the challenges between the public and the private sector working together is that the way that value is articulated is done very differently. But that being said, you can be altruistic and capitalistic and still sleep well at night. That so much of the objectives overlap and so much of the operations are congruent with each other. And I think being able to really understand that and articulate that is an important step towards building meaningful relationships. So,
thank you, Jeff. Whitney, if you could please introduce yourself and add in.
Great. Good morning. Thank you for inviting me. I'm Whitney Schneidman. I'm Senior International Advisor for Africa at Covington & Burling, which is a law firm in Washington, D.C. And I've been working in African issues for more than 30 years. I've served twice in the State Department, worked in the World Bank, but really spend a lot of my time thinking about economic development in Africa and how to leverage the private sector in that process. So I think a lot of what I want to say, and I'll say it briefly, sort of dovetails nicely with what's been said. But let me just start with making one point about the response, what we've seen from other crises. When you look at the SARS epidemic or the tsunami in Asia or the Haitian earthquake or even the HIV/AIDS pandemic, that really hit its strength in the late 1990s. The first response is public sector money, no question about it. After SARS, after the tsunami, after the Haitian earthquake, we saw the regional development banks, the Asian Development Bank, the Inter-American Development Bank, the World Bank, the IFC, come forward with different loans, and these loans were centered on getting business back up and running in many respects. And we haven't quite seen that yet, but I think it's fair to expect it. It's certainly important to advocate for it because it's going to be an important source of resources. Secondly, I think it's really instructive to look at the response to the HIV/AIDS epidemic in southern Africa because you had such a strong private sector response. Yes, the U.S. stepped up big time with about $50 billion and was instrumental in making antiretrovirals available to about 5 to 7 million people over the space of 3 or 4 years. But also huge corporations like Anglo-American and S.A.B. Miller and Ford Motor Company not only took care of their employees, but the employees' families, but in the communities. And to go to Jeff's point, there were no borders. It was really an effort of the public and private sector working closely together. And I think that's what we have coming, and that's what we need to, again, advocate for as we go to figure out this a response to this crisis. My first time in Liberia was in 2006 when President Sirleaf came to the Clinton Global Initiative and appealed for the U.S. private sector to help respond. And I started working with Bob Johnson, who had founded Black Entertainment Television, and he pledged $30 million to help respond to what had been a 15-year civil war in which more than 200,000 people were killed. So it's a little bit like deja vu all over again, sort of 10 years later. But again, you know, one of the things that we were able to do as part of the response is that Mr. Johnson put up $3 million of his own money, and we're able to leverage $20 million from OPIC, the Overseas Private Insurance Corporation, that started making loans in increments of $25,000 up to $1 million to Liberian businesses in an effort to help stimulate the local private sector. And I think that kind of initiative was really quite important. President Sirleaf asked Bob to build a hotel, and we built the first four-star hotel in the country. So I think this sort of gives an indication that it's just vital for the private sector and the public sector to come together as part of the response. Currently in Liberia, you've got something called the Ebola Private Sector Mobilization Group, of which Firestone's a member, but so are other companies such as ArcelorMittal, Rio Tinto, companies from around the region. And their calls every week among the members of this group, and all you have to do to get on the call is to send an email. And this group coordinates very closely with government and with the donors. And, you know, you've heard about the experience of Firestone and its 80,000 employees. ArcelorMittal has about 5,000 employees that it's now able to take their temperatures 5 times a day. So, you know, the infrastructure is emerging here and there. I think the challenge is how do you really spread that and how do you do that quickly? There's another group that's come together. It's called the Africa Against Ebola Trust. And this includes companies like MTN and Econet and Coca-Cola. They're supporting the deployment of 1,000 health workers that are being mobilized by the African Union. So I think you know, where that leaves us is sort of, I think we're at the beginning of a surge of sorts in terms of responding. But, you know, that's overlaid in a country, again, like Liberia, which I know best. You know, the roads are impossible. The rainy season, it's impossible to sort of get from Monrovia up to Gancha, which was one of the epicenters of the Ebola crisis. And so it really comes down to infrastructure, not just health infrastructure, but roads infrastructure, education. And I think, you know, we really have to see this as a holistic response. We have a very near-term and immediate medical emergency, but to really address this fully, it has to be an economic development response. And that means, you know, there are many parts to that. So that's sort of how I come at this, my lens on this crisis, and helping to mobilize business, helping to, you know, the businesses that are there are doing a good job. You know, how can you use what they're doing and leverage those resources? How can you leverage other resources? And I think that's really the challenge, whether it's social impact investing, whether it's, you know, private sector investing. I guess one last point is what I've been most impressed by in my travels around Africa, looking at the health sector, is really looking at the private sector response. You know, there's been such growth in Africa over the last 10 to 15 years, and there's been this large middle class that's emerged, and that has spawned this whole network of private clinics, and they do a really good job of making services available. So something tells me that that's definitely worth investing in. It can be sustainable, and it can play a very important role in making sure that there's not only that an adequate health infrastructure emerges, but it's sustainable and grows over time.
Thank you, Whitney. I think Les is here. Les, are you, do I see you in the back? So the timing is perfect. The train has finally delivered our moderator. And it couldn't be more appropriate to answer some of these questions and direct questions since Les actually wrote the book on investing in healthcare. So, Les, if you could please come up and join us and introduce yourself briefly and then lead us through a series of questions. We'll stay an extra 5 minutes or so for 5 or 10 minutes or so for Q&A from the audience too, since we're a little bit delayed. Les?
Great, thank you very much, and apologies for geographical issues, which in New York shouldn't be as big a problem as it is in Liberia, but I made it into that. Good morning, I'm Les Funtleiter. As Todd said, I wrote the book, Healthcare Investing. My association with Africa is that I'm a consulting partner for Blue Cloud Healthcare, which is actually an incubator that helps get investing into private African healthcare companies. So it's a great segue for me. My day job is actually as a hedge fund manager for E Squared Asset Management, and I've been a professional investor for over 20 years. As in order to spur conversation, I wanted to, talk about my, quote unquote, talking my book, and how, and this for the panel. So you've got essentially mercenary capitalists like me floating around with lots of money. Not me personally, but just in the grand scheme of things. We know that there's a ton of demand in Africa, both because of the economic development and most specifically because of we'll say, the current emerging infectious disease, which is Ebola, but we know there are others coming. How can the private sector, if you're advising a fund, how can we make money? And bearing in mind that we're not averse to actually having a social impact too. I'll open up to the entire panel.
Yeah, I'll just let me take a first cut at that. I mean, it's actually quite interesting. What we've seen is a number of companies, healthcare companies from India, setting up private networks in East Africa. And I think there's clearly an emerging model of providing quality, low-cost healthcare on a commercial basis in major metropolitan areas in Africa, secondary metropolitan areas, and tertiary metropolitan areas. And it's really a question of finding, frankly, the right people to do that and to go implement the model. There's no question from my mind that the model is sound and it's needed, because what happens if you set up a network of clinics, be it Nairobi, be it Monrovia, be it Sierra Leone, number one, you're going to be providing health care, but you're also going to be training people to provide that health care. And over a 3 to 5 year, 7 year period, those people that you're training, they're going to go start other health clinics. And that's how you're going to develop the capacity. So you may call yourself a mercenary capitalist. I see you as a very desired soul. The problem in Africa is not so much the capital. There's a lot of capital that's looking to invest. It's really finding the people to invest in. And Africa is really about investing in Africans and getting the right people together, understanding the environment, working with the government, dealing with the logistics and the infrastructure issues so that you can put that capital to good use and it can generate the returns that will sustain the investment.
I would just add as well, too, that along that point, that there's a lot of investment in Africa right now, and a lot of it's in a variety of areas, from manufacturing to finances to banking to cellular phone networks. And like anywhere else in the world, a workforce that's well taken care of is kind of prerequisite to having the intellectual capital at whatever company it is. And so having an effective healthcare system having hospitals that function, having places where people can seek care, again, is one of these crossover areas where it's in the interest of the government, it's in the interest of the people, it's also in the interests of free-flowing economic activity and in the interest of having a quality workforce that is able to focus on working instead of health. I mentioned as we were talking before the panel, I did my practicum in a second-tier city in Tema, Ghana, which is right outside the capital of Accra, and it's a major port city. And I spent my time at a private hospital there, and spent part of my time in the reception area. And all of the different companies that had set up in this port city had some degree of insurance for their staff. There was a Coca-Cola bottling plant, and they would have the cards with the pictures of their beneficiaries on them. There were some fishing companies that had letters on letterheads, so someone would go to occupational health and then get referred there and then have coverage for that. So having these kinds of resources available, you have a customer base that is also not only in Africa, but that's also investing in Africa, and it kind of creates this snowball effect and it has the byproduct of doing some good for the overall health of the community and improving the business environment beyond the specific investment.
Well, and I also thought you teed up the question perfectly right at the end by saying, hey, how can we make money in Africa? And by the way, we're not opposed to a social impact too. That is the question of social impact in general. And it's no offense to what you do, and why should it be? Money does what money does. Social impact as a concept has been around for quite some time. The term social impact itself is relatively new, or impact investing. But to think that money does anything other than what money does, which is return at its highest available rate, is slowing down the understanding of how we can allocate private capital into public outcomes effectively and efficiently. To think that someone will say, well, maybe I'll accept just a little less this time because I really care about what we're after, is only good for a fairly small segment of sources of capital, family office, some foundations being the leaders of that. We've watched this experience over the last decade, especially within our alliance, which are the sources of capital for these types of funds investing in communities, trying to create jobs and build capacity. To think that we can say, all right, there is some way for us to attract private capital now to this scale of a problem and understand that they may have to take some kind of cutback because they're doing social good is just a non-starter. I'm sure you could be the first to express why that's the case. You have your fiduciary responsibilities. What we do have, however, is an opportunity to understand the relationship that if at one end is return and at another end of this continuum is social impact, trying to believe we can live and pull back and forth in that continuum is actually holding us back from getting more done, especially in a scale of crisis as large as this. As Whitney expressed, the real core, the ground solution here is around economic development. These countries most at risk, most being affected, are those with the least amount of grassroots capacity to do the basics of trying to limit these problems. So I would suggest that let's think less about how you can make money in Africa and more understand how can private capital be allocated and be incented by public sector outcomes in a way that lets you do what you do. Every time we ask you to say, hey, this is a socially good thing, you should consider it, we know generally the outcome is thanks, it's just not really what we do. So the idea that there's a public sector partner here in the middle of your private capital and these outcomes on the other end, this public-private partnership is really where we can spend a lot of time talking. And I think there's already a lot that's been done over the last decade and more to understand that if there is some foundation or public sector that is willing to say, I understand what we're trying to achieve, and we can't get it done through our typical legislative process of pulling down capital from a very limited government budget, we have a great opportunity to say, well, we could be first loss, or we could create a social impact bond because the private capital will say, I'm going after this amount of return based on this amount of risk. The way social impact has been run so far has largely been limited because it says we are going to go after these very difficult challenges and try to compete with what is really private equity returns and also get the social impact. Well, not only have we set them up for failure on a return perspective because those are tough challenges in the first place, but we've also immediately limited the amount of capital that could come to these types of solutions. So if there is some type of first loss provider, albeit be it foundations or some type of public sector payer on the back end, let's say you covered the first 20 or 30% of risk, now the capital, the private capital looking at these challenges can say, all right, the probability that this fund or this vehicle, whatever it may be, would lose more than, let's say, 30% of its principal is low enough that I'm really only looking at a 5 to 7, 8% return, let's say. Then the idea would be that it's not just the capital from their alternative investments portfolio that's relevant. It might be from their fixed income, which is getting similar returns if they're doing well. Now we've changed the paradigm of how private sector engages. If we don't understand the vehicles that the public sector can employ and their willingness to take those positions on an economic impact analysis type of view, I think we'll consistently be talking but not doing in this environment.
Now, that's an excellent point very pragmatic, by the way, from a return perspective, because we care about returns. But can you, or anybody, either describe the mechanics of how this might work, or maybe there are some case studies that we can point to that for when the non-Bill Gateses of the world go and invest, how can they succeed? And are there policy considerations that either from some global UN kind of thing or US or Africa that could encourage this? So would anybody?
Well, I think in terms of policy implications, I'd look to some of the opening up to the private sector that happened in India in the early 90s that really made investment a more viable option for things. You know, and I'm kind of running through my head, you know, again, this how do you explain things to the public health person in me and how do you explain things to the MBA in me? And the, you know, so on kind of a micro level, you know, one of the big challenges with combating disaster is your baseline infrastructure. If you have very, very low or high, not a lot of doctors and a lot of people. Is that a high ratio, low ratio? Anyway, what you need are more doctors, right? So from the public health perspective, from the public policy perspective, it's what are the things that are going to bring in more doctors. But on the private sector, if you have trouble retaining staff because you don't have a functioning healthcare infrastructure, it's the same solution. It's more physicians, it's more clinicians, more nurses, more ancillary staff. So there's a business case to be made. It's maybe articulated differently than in that, but then that also has to be done in a policy environment where that's favorable to the private sector. That and I probably can't speak too intelligently to what those challenges are specifically in Africa, but obviously if there isn't a profit to be made or if there's a lot of risk to being able to either repatriate profits or keep it circulating within the business, then that's going to be a disincentive that's factored into that risk calculation.
You know, I'd just say from a policy sector perspective, virtually every country in Africa has what's known as a Vision 2020 or 2030, where they put forward what their policy objectives are over a number of areas, and health is very, very central to this. So it's essential that any capital coming in is aligned with the country's national development objectives, because that then gives you the basis to engage the government on a policy dialogue, which is going to be extremely important. That's number one. Number two is who's going to be your local partner? How do you find your local partner? Because it's not going to work just to bring, you know, health workers from the U.S. or the U.K. or some external environment and put them in. But partnerships are really what's going to drive this dynamic forward. And I think in the healthcare sector, I am sure whether it's Liberia or Uganda, you know, there, as I mentioned earlier, there are clinics that are up and running, and that there are individuals in those clinics that would be, number one, very receptive to an outside partner coming in, but would be very welcoming of capital to help expand the operation on a commercial basis. And I think this capital can be repatriated and do what capital does, be returned to its investors. But it requires research. It requires on the ground, getting to know the local folks, the local environment, the policy environment, the capacity environment, and then structuring your investment accordingly. But that's what's interesting about Africa today, is that it's happening in sector after sector, country after country, over and over again.
I want to thank everybody who was involved and who came and participated in this. And I wanted to use this opportunity to highlight and thank Louise Rosen and Emily Morris and the Columbia Alumni Association for pulling this together and making this possible. This started with a small business school club idea, expanded into a large university concept, and I think we're going to deliver out some pretty amazing findings and suggestions that can really have an impact on this. So thank you to the CAA, because it's perhaps the only organization that can reach across different programs and help generate idea sharing like that here. So, and thank you for all coming.